Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine Podcast. I'm your host, Yaron Ivan, as usual. And today I have a very special guest with a very interesting topic. So, if you are a pediatric emergency medicine provider in the last few years working in the US or really any other place in the world, you probably heard of something called the Tik-Tok challenges. I'm not going to elaborate on what those are since I have an expert today who will discuss that with us, but suffices to say that social media can sometimes have a very negative effect. So, to talk about the TikTok challenges and how we can better be prepared and treat those patients who present with those challenges or intoxications, I invited Daria, a medical toxicologist and an EM provider, to discuss with us some of those TikTok challenges that have been going through the internet and some of us may have seen in the emergency department. How do we recognize them? How do we better prepare? And how do we treat those patients? Thank you, Daria, very, very much for coming on the show. I'm very appreciative of my guests' time because you guys are all PEM physicians like me, and time is very precious. So let me just introduce you to the PEM Rules listeners. Daria is an EM doctor and a toxicologist. She is originally from New York. Daria, you went to medical school in New York College of Osteopathic Medicine, graduating in 2012. She then completed her EM residency at Staten Island University Hospital and then her Tox fellowship at North Shore Long Island Jewish Hospital, graduating in 2017. Since graduation, Daria has worked as an attending as a PEM physician in emergency medicine and medical toxicology, seeing both adult and pediatric patients. Is that right?
Yep.
And good for you. I admire that. She's currently the director for the Division of Medical Toxicology at Hackensack University Medical Center in New Jersey. Is that right, Daria? Did I omit anything?
Nope, that's it. Pretty accurate.
All right, perfect. So thank you very much, Daria, for coming on the show. How are you?
You're welcome. I'm excited. I'm very, very good. I'm happy to be here. Thanks for having me.
That's perfect. Is this your first involvement in a podcast?
No, I've done one once before, but I'm
right.
No means a professional podcaster.
All right. Well, there's always more goals and future plans to make. So, maybe one day. I don't think I'm unaware. I could be wrong. I'm unaware of any toxicology podcast, so maybe you can start one, and I'm happy to help. So Daria, my first question to you, and if you've listened to the show before, you know what it is. It's the question I ask all my guests, and everybody has their own perspective, which is why it's so interesting. What is your definition or description of a good PEM clinician? One who does what?
I would say, as a mom myself, I would say a good PEM clinician is someone that can really understand that things and complaints that are seemingly benign to us are very scary for parents, and things that seem very routine and easy to dismiss or easy to manage and easily to say, I don't understand why this patient is in the ER are things that are very concerning to parents. And sometimes a little bit of reassurance goes a long way.
I completely agree, 100%. And that's the challenge in our job, because you see this child, they have a URI, nothing else, and they're going to be fine. But parents are very worried. This is why I teach our residents, worried parents don't go home. The classic example is the mom who's very worried about pneumonia. The child is URI, nothing else. But if the mom wants a chest x-ray to make sure there's no pneumonia, you get a chest x-ray, no big deal. Thank you for saying that.
Yeah.
So Daria, recently I posted on the PEM listserv an invitation to a toxicologist to come and talk. I have a lot of guests on my show. I've yet to have a toxicology. And Daria, you contacted me with a great suggestion that maybe speak about the recent TikTok toxicology challenges teenagers have been posting. And I've seen one teenager with similar presentation, and recently read about a teenager who died from one of those TikTok challenges. So I thought it would be a great idea. Daria, why don't you tell us about some of those challenges, how they present and what are they, and then we can get your advice about how to manage those patients.
Yeah, so over the last few years, as social media continues to grow and become a lasting part of all of our lives, more and more challenges, toxicology related and not, have become popular on social media, particularly among our teenage population and young adult population. And so over the last several years, there's been a bunch that have had significant notoriety. Most publicized has been, even I think it was in April of this year, there was a young teenager who died in Ohio after diphenhydramine or Benadryl overdose as part of these challenges. And so what these challenges are, the common theme is that someone creates this challenge, it becomes popular, and the idea is that whoever is going to partake ingests whatever the particular challenge involves. They ingest it, and then they film themselves doing so, and then the effects that happen. And then they post it to social media with whatever the corresponding hashtag is, and that's how it kind of gains popularity when it starts to trend. Obviously, there are adults that participate as well, but our teenage population is particularly vulnerable to these sort of challenges. We could talk first about the Benadryl challenge, the diphenhydramine one, because it's very common. And again, it's had a lot of publicity in the last year because in April there was a fatality from it. Diphenhydramine obviously is an over-the-counter medication, so it's very easily accessible, particularly to teenagers who can walk into a store and buy it with a little bit of money. So it's something that's definitely easy to get and easy to use. People think it's a relatively benign medication because it is over the counter, but in overdose, it can be pretty toxic. So the challenge itself, there's a little bit of variability, but the challenge itself was that people would take 12 tabs of 25 milligrams of diphenhydramine at a time, and they would continue to take 12 tabs at a time until they started having effects. They were hallucinating and things like that. So obviously, there was no set timeline. So depending on how much and how quickly you took it, people can get pretty sick from it. In addition to what we all know and love, the typical anticholinergic toxidrome that you would expect from Benadryl, where people get hypertensive, tachycardic, they can have urinary retention, altered mental status, hallucinations. And the more severe end of the spectrum, patients can have seizures, and then QRS widening and ultimately cardiac dysrhythmias, and they can have fatal outcomes from it. Diphenhydramine in general is a very common, even in suicide attempts, ingestion that I see in the teenage population for the same reasons. It's very easily accessible. But then when it became so public and so popular with this challenge, we certainly started seeing more and more. After this fatality in April, when it became the parents of this young child became their mission to try and give better awareness to this, they pulled a lot of the videos of that particular challenge off of social media, but not all of them. And it certainly doesn't eliminate the knowledge that people have about the existence and also all the other challenges that we see all the time.
So tell us, Daria, if I see a teenager and somehow, because I took good history or the parents noticed it, I realize this is a diphenhydramine, aka Benadryl toxicity, what would be the right way to manage those patients?
Okay. So the board answer that we all know and get tested on, right? The antidote for anticholinergic toxicity is physostigmine. There's a couple caveats to that. There's hard contraindications are in the evidence when there's cardiac abnormality. So if there's QRS or QTC prolongation on the EKG, it should never be given. Also, if you're concerned that the anticholinergic presentation may be related to TCA toxicity for the same reasons. Also, if the patient has had seizures, we generally don't give it either. Or if someone has a history of seizure disorder, it just lowers their seizure threshold. The other big problem is that while physostigmine is the antidote that's very well known and accepted, it no longer exists because the pharmaceutical companies that were creating it have stopped producing it, and everything that had been backstocked in the hospitals has expired. So it's actually not available anymore. In reality, it's not as big of an issue only because we don't use it that often. It works and it works well. But in reality, we use IV benzodiazepines to manage the agitation and toxidrome much more than we use physostigmine. We usually use physostigmine more as a diagnostic tool, where if the patient clinically appears anticholinergic, I might give it, if you have this febrile, altered patient who you're like, oh, maybe I have to do an LP on, versus I think they might be anticholinergic. When you give physostigmine, they wake up, they talk to you, they tell you what they took. It's transient. They go back to being anticholinergic, but at least then you have a good answer, and you're sparing the patient, obviously, a lumbar puncture. In reality, we use IV benzodiazepines. When the patients doesn't have cardiac abnormalities and doesn't have seizures, you just manage them symptomatically. You're going to dose your IV benzodiazepines to their toxidrome, basically. So you can choose any benzo that you're comfortable with. It doesn't really matter. They all work the same, but you want to dose it to the tachycardia, the hypertension, the hemodynamic, autonomic instability, the fever, that sort of thing. When they're sicker and they're on the other end of the spectrum, which is often when I see them, you're going to manage their seizures the same way with benzos. But once they start having cardiac abnormalities, typically it presents first with QRS widening, and you're going to dose them with sodium bicarbonate. So usually we'll bolus them. It's 1 to 2 milliequivalents per kilogram. And then it's a type of thing where you bolus them, you're watching them on an EKG or a monitor in real time. You will see that QRS narrow. And when they have good response, then you can put them on a continuous infusion afterwards. In rare cases where they're very sick and they truly are failing multiple doses of sodium bicarb boluses and drips, we use lidocaine infusions, bolus and infusions. It seems a little counterintuitive because it is also a sodium channel blocker. But the way it works is a much faster binding to the receptor and faster off. So we can knock the diphenhydramine off the receptor and control the sodium channel blockade. There's just a control blockade there.
Very interesting. You clearly know a lot of pharmacology, obviously. That's very interesting. I have déjà vus from med school in undergrad. That's fantastic. So what I hear you say, physiostigmine, the answer on the boards, in real life, benzodiazepines, maybe sodium blockers, and maybe lidocaine.
Sodium bicarb and then lidocaine.
Sodium bicarb, then lidocaine.
Yep. Sodium bicarb is definitely the standard of care. So we do that first and we give it a good effort with a few boluses. But if that ultimately fails, we will try lidocaine.
And what you said about giving them the sodium bicarb and then putting on a drip, please correct me if I'm wrong, sounds a little familiar to the TCA overdoses we used to see.
Yep.
Right. Okay.
Most things in toxicology, overdoses, most things from an overdose standpoint that cause cardiac arrhythmias also cause seizures, and it's the same mechanism. It's just a sodium channel blockade.
All right. Very good. So that's, again, very, very helpful information. Tell us about the next Tik-Tok challenge you were going to talk to us about, something about laundry detergents, I believe.
Yes. So PEM providers, obviously you guys have known about these laundry detergent pods forever because they're a frequent accidental ingestion in little kids. As if that wasn't bad enough. Now there's a more recent social media challenge where, you guessed it, the challenge is to film yourself biting into one of these pods. Depending on which challenge it is, some of them involve like biting into it and then spitting it out or actually ingesting the pods. And you get the toxicity that you have probably seen in young kids, right? So there's 2 different toxicities we expect. The contents of the pods themselves are actually caustic. So they can cause oropharyngeal burns. And if they're ingested and swallowed, they can cause significant GI burns, right? So esophageal and gastric burns. In addition, those pods are packaged very tightly in there. They're under high pressure. So when you bite into them, which they're not designed to be bitten into, it's very high risk for aspiration. And so we see the same sort of syndrome in little kids when they do it accidentally because they're very colorful and usually very appealing. When you aspirate them, you can get pretty significant respiratory distress. All the damage that they can do in your GI tract, it's the same sort of thing. Some young kids, they get altered mental status. You can get ARDS. We think it has to do with the effect on like the surfactant in your lungs, but they can get pretty sick. And so this was also another recent challenge. More recently, it's kind of evolved a little bit. I saw recently that there was a new challenge where people are putting these pods on pizza and now ingesting them with pizza. It's another social media challenge. Yeah, when they get found and like they sort of pull some of the videos off, they kind of change it a little bit and then move on. The Benadryl one was the same thing. Recently there was this, it's called sleepy chicken, where people are like cooking boiling chicken in NyQuil, which contains most of the time diphenhydramine, acetaminophen, and that's another one. So it just keeps changing on a daily basis, it seems like.
Wow. I'm impressed by people's creativity, I got to say. I wish all that creativity was put to use in some other way. I imagine such an ingestion, the treatment will be supportive care. Anything else we should know? What else can we do for those patients?
Yeah, it's honestly, it's primarily supportive care. The important thing from a respiratory standpoint, it's supportive care. The kids can get pretty sick. I've had plenty of them that have needed PICU admissions, a few that have been intubated. If they are having respiratory symptoms, you don't have to get a chest X-ray on these patients unless they're having respiratory symptoms. If they develop respiratory symptoms or distress, then obviously you can get a chest X-ray. If you see something on the X-ray, it's a worse prognosis. They definitely need to be admitted. You need to keep them for at least overnight. The other thing too to remember is with all caustics, if they have signs of GI symptoms, right? They're nausea, vomiting. If you see oropharyngeal burns significant, they usually will have to stay because they may need to be scoped. They may need endoscopy with GI. The important thing to remember too with all caustics, sometimes their mouths can look terrible, right? They can have terrible oropharyngeal burns. It's actually not a good predictor of what sort of GI burns that they're going to have lower down. Very long time ago. It's one of the older tox studies, but very well done. They had a whole bunch of young kids who ingested all sorts of caustic things. And every kid that presented to the emergency department ultimately had an endoscopy done. And they showed that there was no correlation between what you see in the mouth and what you see in the GI tract. Things like drooling, stridor, that sort of stuff is much more predictive of what they'll see on scope. But if you have kids with those symptoms, then they may need to have GI involved.
Very good. Again, Daria, this is super helpful information. I appreciate it. You clearly are very comfortable with this and have seen it and know so much about it, and it's great to hear. I'm going to ask you, Daria, one more question. And this is actually very relevant because just 2 days ago, here in Vegas, I had parents presented to the ER. They just came to Vegas. They went to the hotel. The hotel is wall-to-wall carpets, and before they know it, they're 14 months old, picks up a pill from on the carpet and puts it in his mouth, and it starts dissolving, and the father was able to get just some of it out. And the kid came in, and in my head I had a discussion with the resident. I have the one pill can kill list. So let me just share with you what I quickly remembered, what we quickly did, and I'd love to hear your opinion. So in my mind, I think about the hypoglycemic agents like sulfonylureas and the calcium channel blockers, the beta blockers. So we immediately got EKG and we immediately got glucose. Both of those were fine. And then I kind of maxed out and had to look through more information because I couldn't remember the rest. But tell me first, was that the right move? Check the glucose, check the EKG for those two. And then it seemed like the rest of the list was certainly concerning, but a little bit more benign and a little bit more involved in terms of workup. Is that right?
Yeah. So that's definitely a great place to start, getting good set of vitals, and EKG, a finger stick for sure. There's a few, it's probably a longer list of pediatric one pill or one step killers. The most common ones that we see present to the ER most frequently certainly are the sulfonylureas. And the biggest concern there is obviously hypoglycemia. In adults, those medications are very long acting, right? So at least 24 hours. And in kids who are not meant to be taking these medications, even longer so. So they usually will require an admission with an extended observation period, depending on whether they get hypoglycemic or not. The other big one too is your opioids, all the opioids, right, which are very common. They're everywhere, are one pill killers, right? The same things you expect in adults or teenagers, you see in the little kids too, where they get pretty significant respiratory depression. In addition to the pills, children who have parents who are on methadone for substance use disorders, that methadone in particular is in the liquid formulation, and it's a pinkish red formula. It kind of looks like fruit punch. And patients that have been stable on them for a long time with a stable dose, they will get multiple days to take home, especially over weekends, holiday weekends, that sort of thing. And even though they're told and they have to sign contracts to keep them in a lockbox, it is not uncommon that kids get into it. Same reason that the laundry detergent pods are appealing. It's a colorful liquid. It looks like it might be good. And again, it's methadone. So in addition to being an opioid, it has a very long time frame in which you see its clinical effects. So that's obviously something to worry about. And then, like you said, the calcium channel blockers, the beta blockers, also any of these medications, especially when you know what they are. If it's unknown, it's a little bit different. But if it's an exposure from someone that is prescribed the medication in the house, it's always important to know whether it's immediate release if it's extended release. It gives me an idea of when I could tell you when to expect toxicity, right? If someone comes in an hour after ingestion and they're fine, that's great, but it may not make a difference if it's an extended release preparation and the medication doesn't peak for hours afterwards.
Excellent. Yeah, so perfect information. Again, Daria, this was super helpful for us, all of us PEM clinicians. This is one of those topics that we really got to know everything about, but we don't see it very often. So it's very challenging. So I appreciate your expertise. Wonderful information. Thank you very, very much for coming on the show. Lastly, Daria, tradition in the PEM Rules podcast, every guest who gave me of their time get to choose the outro I will play for the episode. And I guess you like Bon Jovi, is that right? You like
I
Bon
do,
Jovi?
I do.
All right, fantastic. My family like it too. I like him as well. And you wanted to hear "Living on a Prayer."
Yep.
All right, classic. "Living on a Prayer" by Bon Jovi. I guess I'm gonna have to learn that. Thank you very, very much. Have a great day. And if anything comes up, I would be happy to do that again. I'm sure more TikTok challenges will rise.
Yes. Thank you for having me. I appreciate it.
Thank you. And that is it for today, guys. Thank you very much for listening and supporting PEM Rules. I truly appreciate it. Please continue to write back, give any feedback, check out the website, check out the episodes, check out the Facebook page, which again doesn't have a whole lot. Read my articles on EP Monthly. And if you have any comments, if you want to come on the show like Daria to discuss interesting topics, please contact me. Again, this is Bon Jovi, Living on a Prayer. Hopefully you like it. Thanks very much.